Hello everybody and welcome to this talk on Hodgkin lymphoma. I'm John Radford, I'm Professor of Medical Oncology at the University of Manchester and the Christie NHS Foundation Trust, and I'm also President of Lymphoma Action. It really is a pleasure to talk about this subject that I've focused on for a number of years, and I hope that you find it of interest and provides you with some understanding of the disease and its treatment. The first slide shows a picture of Thomas Hodgkin himself. He was alive in the 18th century, 18th and 19th century, 1798 to 1866. He was a British physician based at Guy's Hospital in London. And he specialized in pathology and was a pioneer in preventive medicine. And the claim to fame for him in terms of Hodgkin lymphoma was that he produced one of the founding papers of modern histology with his colleague, Dr. Lister. And here's that paper on the slides, entitled "On Some Morbid Appearances of the Absorbent Glands and Spleen" by Dr. Hodgkin. As you can see, it was read in January 1832. And what it described was a series of 7 patients on whom Thomas Hodgkin had performed autopsied. And he described a malignant process that was producing enlargement of lymph glands, enlargement of the spleen and liver, with invasion of other tissues too. And this is, of course, what we now recognize as Hodgkin lymphoma, but this was just a very early description of the macroscopic appearances of patients who had died and for whom autopsies had been performed. And what was interesting, he personally treated one of these patients with sarsaparilla, which I think is just a flavoring for drinks, but nevertheless, that's what he did. And in terms of recognition of this, Sir Samuel Wilkes was a contemporary of Thomas Hodgkin who some 33 years later rediscovered Hodgkin lymphoma after Hodgkin's original description, and it was Samuel Wilkes who assigned the eponym of Hodgkin's disease. And he also wrote biographies of Hodgkin himself, Addison, and of course Addison's disease, and Bright's disease, both of which are well-known eponymous diseases. And then in 1872, someone called Langhans published the first description of the histopathologic features of Hodgkin's disease. In other words, the appearance of these tumors under the microscope. And the history carries on because in 1878, Greenfield published the pathology of lymphomas with the histopathologic features of Hodgkin's disease. So this was recognizing that there were other types of lymphatic cancer other than Hodgkin's disease. And then in 1894, Osler, in his textbook of medicine, was the first to mention the use of chemotherapy for lymphoma. So that was at the very end of the 19th century. And in 1898, Carl Sternberg first provided a detailed description of the giant cells which are absolutely characteristic of Hodgkin lymphoma and which are now called Reed-Sternberg cells. And the Reed part of that name was from a woman called Dorothy Reed, who in 1902 independently described Reed-Sternberg cells. So it's a really fascinating history from the time that Thomas Hodgkin first described the appearances in people who had died with the disease, right through to describing the appearances under the microscope, and then the absolute pathognomonic or the characteristic findings of so-called Reed-Sternberg cells by Sternberg and Reed, and that was at the very end of the 19th century and the beginning of the 20th. So a history sort of just sets the scene, as it were. So if we look at the pathophysiology, in other words, what is it that constitutes Hodgkin lymphoma? Well, this is a diagram that shows that lymphomas are cancers of lymphocytes. So these are small cells which are present in lymph glands throughout the body and are also circulating in the blood. And as you can see, the various lymphocytes create various types of cancers. So acute leukemia is derived from the hematopoietic stem cell. So these are cells that can move in very many different directions. The chronic lymphomas, or the chronic leukemias, I should say, are derived from other cells that are derived from the multi-potential stem cell. And Hodgkin lymphoma is derived probably from the B lymphocyte. Myeloma is derived from the plasma cell. So this is where the hierarchy of cells arise, and this is how we think they develop into the tumors that we recognize. And if we look at the way in which we think that these cells develop into Hodgkin lymphoma, here's a little cartoon that shows the B lymphocyte on the left, possibly affected by the Epstein-Barr virus, EBV, to create the Reed-Sternberg cells, which there's an arrow there that says loss of apoptosis, which means that it loses its ability to die when damaged, so it persists. And so that is the RS cell that we see under the microscope, which is characteristic. And the RS cell produces cytokines or substances that produce an inflammatory response in the affected lymph node. And it's of interest to note that here's the Hodgkin Reed-Sternberg cell under the microscope. It's a huge cell with those big nuclei looking out at us like a pair of eyes. And surrounding are other cells, which is the tumor microenvironment. So the malignant cell is the Reed-Sternberg cell in the center there, and all the surrounding cells is an inflammatory response to that Reed-Sternberg cell. And what is critical is that the Reed-Sternberg cell forms only about 1% of the tumor, and the rest of it is comprised of all these other many different cells, which is the response to the substances produced by the Reed-Sternberg cells. Hodgkin lymphoma is categorized into two main types. There's the classical type, which comprises the majority, and that has some very characteristic features. I've mentioned the Reed-Sternberg cell, and there are also certain targets, one of which is called CD30, and that is universally positive in classical Hodgkin lymphoma. And we can define various subtypes from their appearance under the microscope. So you might have heard of your doctors speaking about nodular sclerosis, mixed cellularity, lymphocyte depleted or lymphocyte rich. The most common is nodular sclerosing. And then there's a nodular lymphocyte predominant variant, which is much rarer, has a different natural history, and has different appearances under the microscope. So just to summarize, Hodgkin lymphoma in the majority of cases is of so-called classical type. It is CD30 positive. The nodular lymphocyte predominant type is much rarer, about 5%. It has a very different natural history, and this is CD20 positive. So if we just look at the epidemiology of Hodgkin lymphoma, we should recognize that it's a rare cancer. There are only about 2,100 new cases per year. Obviously, for those individuals, it's very important, but in the grand scheme of things, this accounts for less than 1% of all new cancer cases. But in the TYA population, teenage and young adult population, it is the commonest cancer. And this is because it has a predilection for those younger ages. If we look at the incidence of Hodgkin lymphoma by age, and we're talking here about classical Hodgkin lymphoma, which you'll remember comprises about 95% of all the types that we see, we can see that there's a steady rise to a maximum level of incidence in the 20s and 30s. And then beyond that time, the incidence decreases, it doesn't go away. And then there's a further peak, although not as high as this one, in the 70-year age group. So this is a disease predominantly of younger people. And as I pointed out, there is a second peak of incidence in the 70-year-old age group. And if we look at the incidence over time, so this is looking at the number of diagnoses made per year, we can see that there is a slow but steady increase in the number of patients diagnosed. The purple line is female, the blue line is males, and the purple line in the middle is everybody. And as we can see, the rate per 100,000 per year is in the region of about 2 to 3 per 100,000, but that is a slowly increasing trend upwards. Now, some of this may be because it is actually increasing in incidence, or it may be that some of the other lymphomas that were previously diagnosed as non-Hodgkin lymphoma are now being more correctly diagnosed. And we know that this is the case as histopathology gets better and better and more accurate. So in terms of diagnosis and workup, what do we do? Well, the lympho-reticular system comprises a network of lymph nodes connected by lymphatic tissue. And those lymph nodes typically are in the region of in the neck, under the arms, in the groins, but also within the body cavities, surrounding the root of the lungs, the root of the bowel, and also involving the tonsils in the throat, and also the spleen and liver. So this describes the overall lympho-reticular system. Hodgkin lymphoma can occur in the bone marrow, but it's relatively uncommon compared with non-Hodgkin lymphoma. But I think the message is Hodgkin lymphoma can present anywhere, although typically it will produce a lump in a lymph node. And the classic description is of a young male finding a lump in his neck while shaving. That is the sort of typical way in which people describe the presentation of the disease. But of course, some individuals might not develop any visible lumps at all, and they may just become systemically unwell with various symptoms. And the symptoms that we can expect in Hodgkin lymphoma either occur from the effects of the lump itself, of the mass, and bearing in mind that the lump is usually in the chest, that can produce cough or chest discomfort or pain or shortness of breath, or something called SVCO, which stands for superior vena cava obstruction, which is where the lump is pressing on big veins in the chest and causing swelling of the neck and face and producing quite a different appearance in the mirror. But in addition, those cytokines, those substances that the Reed-Sternberg cells produce, can cause drenching night sweats, fevers, weight loss, anemia, fatigue, an increased risk of infections, and itching. So all of these are possible. The key to the diagnosis is histopathology and a good biopsy. And so typically these days that will involve a needle core. That's convenient. It means that people don't have to have a general anesthetic in most cases, and it can be done quickly. But sometimes the tissue obtained is not large enough, it's not representative, it can be fragmented, and the biopsy has to be repeated. In years past, it was an excision biopsy where patients had an anesthetic and the whole lymph node was removed. That produces the very best diagnostic sample, but it's not convenient. And so what the pathologist does is look at these samples under the microscope. They're first fixed in formalin so that they are preserved forever, set into wax, and then sectioned. And it's those sections that are examined following the use of various staining, and you can see the various markers that are used. And in addition, we use molecular tests as well. And this is a very specialized area. And these days, histopathologists are producing diagnoses on the basis of great expertise and seeing many cases over the course of the year. And pathologists are now linked together into hemato-oncology diagnostic centers so that we can be really sure that the diagnostic accuracy is extremely high. PET scanning is something that has really taken over in terms of the staging of Hodgkin lymphoma. And these two images on the left in limited stage and on the right in advanced stage Hodgkin lymphoma, if we look at the left-hand picture first, you can see that in the upper part of the, where I'm just putting my cursor now, there is some increasing coloration here. This is due to the uptake of the radioactive dye, and this is due to limited stage Hodgkin lymphoma. In the right side, it shows left on the screen of the neck and so-called supraclavicular fossa. In the right-hand side of the screen, we can see multiple areas of abnormality involving lymph nodes, both under the arms, in the chest, multiple deposits in the spleen, multiple deposits in the liver, further lymph nodes in the groins, and involvement of the bone and bone marrow here. You can see those two specks in the upper part of the legs. So on the left, limited stage disease, on the right, advanced stage disease. And in terms of the workup, we've talked about the importance of histopathology, we've talked about PET, the importance of the history in terms of understanding what has brought the person to the position they're at now in terms of duration of symptoms, types of symptoms, the physical assessment to feel for an enlarged spleen or liver, to measure and identify the lymph nodes that have enlarged, various blood test results. And then, of course, all of that is brought together in the lymphoma MDT, the multidisciplinary team meeting, when the various specialists, oncologists, hematologists, radiation experts, nurses, imagers, and pathologists all bring their expertise to bear so that we can give the very best decision with respect to treatment. We might want to arrange an echocardiogram in patients with known heart disease or risk factors. And for people younger and wanting to preserve their fertility, gamete cryopreservation, either spermatozoa in males or oocytes in females, is arranged. And we then calculate risk scores to, as it were, guide our next steps in the process. 55% of people have stage 1 or 2 at diagnosis, and 45% 3 or 4. So that's the distribution. It's approximately half and half. Let's move on to treatment. This is a timeline of the various uses of therapy in Hodgkin lymphoma. So right back in 1925, that was the description of radiotherapy use in Hodgkin lymphoma. About 18 years later, Goodman and Gilman described the use of a single drug. It was nitrogen mustard, which showed a very rapid but only temporary remission of the disease. And on we go. In 1952, before CT scans, of course, it was possible to identify lymph nodes for the first time using something called lymphangiography. And then in 1962, Kaplan described wide field radiotherapy in terms of producing better outcomes, and the so-called mantle and inverted Y fields of radiotherapy were described. And then in 1966, there was the first description of a 4-drug combination, and the benefit of that over single uses or single drugs. In 1969, there was the description of staging laparotomy, where people actually underwent an operation. The abdomen was opened, the spleen was removed, lymph nodes were biopsied to really identify the sites of disease. Again, this is still pre-PET and in many cases pre-CT. And then in 1970, Vince DeVita provided the first evidence of curing Hodgkin lymphoma using MOP chemotherapy. So that was based on mustine, which is a nitrogen mustard, that's the M, and the other drugs were O oncovin, P procobzine, and P prednisolone. And that was the first evidence that we had that combination chemotherapy could cure people with Hodgkin lymphoma. And then things continued, and the last one was Johnny Bonadonna in 1973, the idea of non-cross-resistant chemotherapy, ABVD, and the use of alternating regimens. And since then, further developments have taken place. But ABVD was the real breakthrough, I think, after the development of combination chemotherapy with MOP. And ABVD, of course, persists to this day in various guises, including the original combination. And we just need to bear in mind that all these treatments, and of course at the beginning it was a case of trying to find something that actually worked and led to remission, cures in some cases. But increasingly over the decades, we became aware of the fact that late toxicity was an important part of the mix. And in addition to the obvious psychological effects, there are other direct effects on various organs. The heart, the lungs, the hormone-producing organs such as the thyroid, the risk of second cancers, and the impact of treatments on the bone marrow. And if we think about cardiac effects in particular, the anthracycline drugs, doxorubicin, epirubicin, and others are known to be cardiotoxic. And we also know that radiotherapy given to sites above the diaphragm can affect the heart. And we also know from a big epidemiological study that vincristine and vinblastine might also have an effect on the conducting system of the heart and lead to an increased risk of late toxicity. And this is something that was brought together by Tony Swerdlow, who is a professor of epidemiology at the Institute of Cancer Research at the Royal Marsden Hospital. And he described a follow-up study in more than 7,000 Hodgkin patients treated in the United Kingdom from 1967 through to 2000. And in that group, there are 166 deaths from myocardial infarction. And from knowledge of the incidence of myocardial infarction in the general population, this risk, or the standardized mortality ratio, is 2.5 times that background risk, which is really quite intriguing. And it's higher still in those treated with ABVD, where we know that doxorubicin has a specific cardiac effect. And so what this tells us is that although these treatments are extremely useful and are curing patients, and that's something to be really pleased about, we have to be aware of the late toxicities, because these can undermine the duration and the quality of survival. And so what we actually give in treatment is really important, and wherever we can, we need to try and reduce treatment to that amount that is sufficient to get rid of the disease, but limits the late toxicity of the treatment itself. And this slide shows the results of two studies, one done by the EORTC, LISA and Phil group, their H10 trial, and also the results of a trial that I led, the RAPID trial, and this was published in the New England Journal of Medicine in 2015. And In the latter study, in the Rapid trial, we showed that it was possible using PET imaging to identify a group of patients who could be treated very successfully with chemotherapy alone without the need for additional radiotherapy. So this is the whole concept of response-adapted treatment, where we change the treatment on the basis of what the results look like. So this is in limited stage disease. And this slide shows that PET is a really important way of discriminating between patients who are doing really well on treatment and those who are doing less well. And what it shows is in the upper horizontal line in both panels shows that the outcome is very much better if the PET scan is negative after an initial 2 cycles of treatment. So that's the so-called PET2 result. If PET2 is negative, the outcome is predicted to be extremely good. If PET2 is positive, the results are likely to be less good. So this slide just describes the big UK NCRI trial Raffle in advanced Hodgkin lymphoma. And what we did here, and this was a study led by Peter Johnson, was that a baseline PET was performed. Patients had 2 cycles of ABVD and then had their second PET scan, PET2. If that was positive, and I've already explained that suggests that the outcome isn't going to be as good as we hope for, then for these individuals, patients had an escalation of treatment to BIACOP 40 or escalated BIACOP, a much more intensive therapy. And following that, patients who were PET negative completed their course of the BIACOP. If it was still PET positive, patients had radiotherapy or at investigator discretion, a salvage regimen. If, on the other hand, the PET2 result was negative, that would suggest that treatment was going well, and these individuals were then randomized between either continuing ABVD or 4 cycles of AVD with the bleomycin dropped. And that's an advantage because it means that we're not causing lung toxicity, which we know bleomycin can cause. So this was a very nice demonstration of the use of PET to modify treatment. So this is PET response adapted therapy. And what we showed is that in terms of the PET negative group, both in terms of progression-free survival, so this is time to progression or death, or overall survival, time to death, there is no difference in outcome between those patients receiving ABVD and those receiving AVD, thus supporting the view that doing a PET scan after 2 cycles is a very good way of discriminating between patients who are doing well and those who are doing less well, and allows us to make a difference to the treatment itself. And in terms of the PET positive patients, this only comprises 16% of the total. We can see that there's no difference in either 5-year progression-free survival or 5-year overall survival, whether we use escalated BIACOP or BIACOP 14. So let's think about relapse. What happens if the disease unfortunately comes back? We should bear in mind that following the approaches I've mentioned, either with the Rapid trial in limited stage Hodgkin lymphoma or the Raffle trial in advanced stage Hodgkin lymphoma, most people will be cured, but there are some people who do get a recurrence. And then what do we do? And in general terms, certainly in advanced disease, we would suggest using a non-cross-resistant chemotherapy regimen followed at remission by high-dose chemotherapy and an autologous stem cell transplant. And what we know is that that prolongs the outcome, the progression-free survival, compared with chemotherapy alone. But unfortunately, somebody who has 1 relapse, there's a 50% chance that they will have multiple relapses. So for the people who relapse, 50% will be cured by having further chemo and a transplant, but unfortunately 50% will get further recurrences. And the question is, what do we do in those circumstances? And what we also know is that using ESHAP, which is a common second-line chemotherapy, if we use prior to transplant, the outcome of the treatment with ESHAP really predicts what's going to happen in the future. So if somebody has a complete response to ESHAP, then that shows in the top line here that the outcome is not too bad at all. There are still some relapses, but it's not too bad. If it's only a partial remission, the results are much less favorable. And if it's only stable disease or progressive disease, really the results are very poor. So what we're trying to achieve in the relapsing patient is complete response, using, in this case, further chemotherapy. This is a intent to treat by pre-autologous stem cell transplant response, and showing once again that if you got a negative result with that initial treatment after relapse, and this is using GVD or so these are another set of salvage chemotherapy regimens, the outcome is much better than if the PET scan is positive. So it's really important to try and achieve complete response. And what we know is that for those people who fail autologous transplantation, in other words, if having gone through ESHAP or ICE or something else and then had a transplant, if the disease then comes back, the outcome for these individuals is really not very good at all. And so we really need to think about alternative therapies in these circumstances. One different way of doing a transplant is to use allogeneic stem cell transplantation, which is where, rather than giving bone marrow cells from the patient themselves, the so-called autologous, we use stem cells from a different matched donor. And that is designed to provide a different population of cells that can recognize the tumor and eradicate it. One of the problems is that there is a high transplant-related mortality, or TRM, and this is in the realms of 40% where patients have been treated earlier in the course of their disease, so the use of allo early on, but that's still very high. But for patients where it's being used later in the course of the disease, the treatment-related mortality is even higher. So allotransplantation is an interesting way of treating difficult Hodgkin lymphoma, but it does have some risks, and this has to be discussed very openly with patients. And this is a slide that just shows the data from various studies that have been published. And as you can see in the right-hand column, this is the overall survival at between 2 and 3 and 4 years. And as you can see, this varies between 32% at 3 years to 56% at 4 years. So this is not the answer, but it can be helpful in certain carefully selected patients who are fit enough, young enough, and have the right match of bone marrow cells. Something that is interesting, that is different to autologous transplantation, is that unlike in the autologous situation where it's really important to have a negative PET scan pre-transplant, in allotransplantation, it doesn't look as though that is absolutely required. So long as you've got responsive disease, so response on the PET scan, and no evidence of failure to respond or progression, then the outcome following allotransplantation looks to be very much the same. So that's the difference between autologous and allogeneic transplantation. What about new agents? So we're on the lookout all the time for new approaches to treating resistant Hodgkin lymphoma. And for many years, there was a real dearth of of new therapies, and we were really limited to using the tried and tested drugs that had been developed many years ago in combination with radiotherapy. And we were limited to either using single agent chemotherapy, radiotherapy, best supportive care, and trying to transplant people if we could get them into remission. But this really wasn't very satisfactory. And so the first excitement came with the development of brentuximab vedotin, which is a so-called antibody drug conjugate. And what it comprises is an antibody, which is a specialized protein, which is linked by a cleavable linker. So that means it can be broken. And it's linked to a toxin, which in the case of brentuximab vedotin is something called monomethyl auristatin E, MMAE, which is a potent poison of the microtubular structure in cells. And so what happens, and this is shown in the lower part of the slide, the antibody drug conjugate binds to CD30, which, if you remember from an earlier slide, is a protein on the surface of the Reed-Sternberg cell. This attachment is then internalized into the cell. The chemical nature of the internal parts of the cell mean that the cleaver can break, and so releases the drug into the cellular structure, where it does its damage, disrupting the microtubule network, and effectively means that that cell can no longer divide. So that is the cartoon describing its mechanism. And what we were very excited about was in the phase 2 pivotal study of brentuximab vedotin, we found that 94% of patients had some sort of response. And that really is extremely exciting when you're faced with patients who have not been responding or have relapsed after previous therapy. And this is a so-called waterfall plot that describes the amount of tumor reduction. So this is the percentage change on the left-hand scale, and each of these bars is an individual patient. And as you'll see, some people have dealt a complete response in blue, a partial response in green, stable disease in grey, and you can just count 3 cases where there was actually progression of disease. So very exciting data indeed. And what we found was that there was once again very strong correlation between PET positivity and poor outcome, and PET negativity and good outcome. And so this is the pivotal study and its effect of brentuximab vedotin on progression-free survival. And so what happened is that it was granted accelerated approval by the FDA in 2011. Myself, Andreas Engert and Tom Hagenbeek presented these data to the European Medicines Agency in October 2012, and following that, provisional licensing was approved, not only for Hodgkin lymphoma, but also for anaplastic large cell lymphoma. And then in 2017, the Cancer Drugs Fund funded, or sorry, until that time, it was CDF funded until 2017, and then a nice technology appraisal was positive, and it is now routinely commissioned by NHS England. So this is a sort of description of the development of a new drug, the phase 1, the phase 2 clinical trials, presentation to regulators, approval by them, and then support in the UK by the Cancer Drugs Fund, and then finally approval by NICE, which shows that which shows the benefit and cost effectiveness of the drug, and it is now routinely commissioned. You may also have heard quite a lot about immune checkpoint blockade, and this is a rather colourful, slightly complex diagram that shows the interaction between the tumour cell at the bottom of the slide and the tumour-specific T cell at the top. And what this is describing is drugs that essentially release the handbrake on the immune system. So normally in health, there is a careful regulation of the immune system so that it reacts appropriately to invading bacteria or viruses, or how it deals with developing tumors. So we want an immune system that works but doesn't overreact. So what happens in tumors is they're very clever and they can evade surveillance. And what we're doing using these various so-called checkpoint inhibitors is to mean that the cells of the immune system get a better view of the tumor cells and can attack and destroy them. And so the two most important drugs in this setting in Hodgkin lymphoma are PD-1 inhibitors, nivolumab and pembrolizumab. So these are the two drugs that have now found a place in the treatment of the disease. And what would appear is that in lymphoma, nivolumab has the most use. And as you can see at the left-hand side of this slide, the column is the overall response rate around 85%, with the dark blue is the proportion who are achieving complete response, and the pale blue in achieving partial response. And as you can see, the effectiveness of nivolumab is decreasing as we move through other types of lymphoma into melanoma, which is a skin cancer, renal cell cancer, a kidney cancer, and a type of lung cancer called non-small cell lung cancer. So in Hodgkin lymphoma, nivolumab appears to be really quite a useful drug. What is interesting is that both for nivo and pembro, response rates are high, but the disease doesn't go away. So what we frequently see in the clinic is that patients who have failed prior lines of therapy, the nivolumab or pembrolizumab is commenced, patients feel better, the tumors shrink, but the proportion of people achieving CR, complete response, is rather small. And so there's a big question mark about how best to use these drugs. Do we continue on them indefinitely, or do we move across to transplantation at a certain point? And that transplant is usually an allogeneic transplant, but auto is also employed. So this is again an illustration of how important it is to understand what the results of any particular drug achieve. Is it producing cure? Is it producing response? And if so, what sort of response? And do we need to do anything else after that response has been achieved? What we know also is that although these are not chemotherapy agents, and so the chemotherapy-like side effects don't occur, we still get side effects of a different type. And what we can get is a type of autoimmune condition with an effects on the lungs, on the thyroid gland, on various other organs as well. And so there are some very specific toxicities that we need to look out for, and something that we need to warn patients about. But in general, we found that these drugs are really quite well tolerated. We just have to be aware of the potential for toxicity and how to deal with them. We also have to be aware of a phenomenon called pseudo progression, which is when we first start a checkpoint inhibitor. Those checkpoint inhibitors mean, of course, that lymphocytes can invade into the tumor because that's what they're doing. They're seeking out and destroying cancer cells. But it can, in the short term, lead to an enlargement of that area. So there's a phenomenon called pseudo progression, where it looks as though the disease is increasing, when in fact the disease is responding and the mechanism is being demonstrated. So this is something that we sometimes see. The scans may initially look worse. On the left of this particular slide, you can see the baseline scan with some positivity in the chest. On the next slide, actually after 4 cycles of nivolumab, the appearances look worse, and you could be forgiven for saying this treatment isn't working. But after 6 cycles, you can see that things have improved and that pseudo progression phase has passed, and in fact, the patient is better and responding to therapy. So the final drug I'd just like to mention is another antibody drug conjugate, and it's something we've been working with in combination with ADC therapeutics. This is there are 2 drugs, one in Hodgkin lymphoma, ADCT301, and this is something called camidanulab, and another one, ADCT402, loncastuximab, and the latter is used in non-Hodgkin lymphoma. But in terms of the Hodgkin lymphoma, this is an antibody drug conjugate, so rather like brentuximab vedotin, a specialized protein that identifies a particular protein on the cell surface, in this case CD25. And that combination, the drug links onto that receptor. It is internalized in step 2. The linker is broken, and the drug, the PBD in this case, pyrrolobenzodiazepine, is released, and that does its damage in the cell nucleus, preventing the separation of the DNA strands, and so preventing cell division. And at the bottom of the slide here, you can see that PBD is extremely potent. So compared with some other cellular toxins, it is far more potent. In other words, at much lower concentration, it is producing much higher cell kill rates than those drugs that are other drugs used in these circumstances, auristatin A, calicheamycin, maytansine. And if we look at the right-hand side with the familiar chemotherapy drugs, methotrexate, doxorubicin, dornamycin, and vinblastine, which are far less potent compared with the PBD. And so this is a drug, camidanulab, or ADCT301, that we're investigating in patients with relapsed and refractory Hodgkin lymphoma. And here we've got a little bit more information about it. It binds to the CD25 antigen, it's internalized, there's cross-link formation, and that prevents the development or prevents further cell division. And if we look at the response rates, these are different dose levels: 30 micrograms per kilogram of body weight, 45 micrograms per kilogram of body weight. And as you can see, it would appear that the higher dose produces a somewhat higher response rate, with 13.5 with an overall response rate of 86.5% versus 50% at 30 micrograms per kilogram. And this right-hand column is the overall response rate for both doses. So we've had an interesting question about the difference between remission and cure. So this is something that is the topic of conversation in many consultations. So what we're trying to achieve in the first instance with Hodgkin lymphoma, in fact in any lymphoma, is to achieve remission. In other words, where there is no evidence of disease, either on clinical examination or on scan, and that the person has returned to normal health with a resolution of all the previously noticed symptoms, so no lumps to find, no sweats, weight is returned to normal and is stable, and so on. So that remission is where there is no current evidence of disease. When that changes into cure, that is following a period of time when there has been no relapse in the intervening time. And so typically what we know about lymphoma is that most relapses in the curable lymphomas are likely to occur in the first 2 years. And by the time we get out to 5 years, the risk of relapse in curable lymphomas is very low indeed. And beyond that point, we can start to talk about cure. So remission, if you will, is the first step. It's the resolution of disease and the resolution of symptoms. Cure is when nothing has happened in the meantime, and we can believe that the disease is no longer present at all and is not going to come back. And of course, everybody wants to be cured. Sometimes in incurable lymphomas, achieving remission is absolutely good enough, because we know that even by giving more and more treatment, we're not going to cure the disease, but having achieved a remission, the individual concerned is well, and if and when the disease comes back, further treatment can be offered at that time. So remission is a very important state to try and achieve. Cure is something that everybody wants, but is sometimes an unrealistic ambition, but it is something that clearly we want to strive towards wherever we can. An interesting question about staging in lymphoma. So what we just need to remember is that this is somewhat different to other cancers. Stage 1 indicates lymph node enlargement at one site. Stage 2, lymph node enlargement at 2 sites, but in either the upper or lower part of the body. Stage 3 is lymph node enlargement in the upper and lower parts of the body, and stage 4 is disease in organs apart from lymph nodes, so perhaps the bone marrow or the liver or the lung. This really describes the extent of the disease and the anatomical site of it. Patients with stage 4 lymphoma, if they've got a curable lymphoma, can still be cured. The outcomes are not as good with stage 4 disease, but they are still absolutely treatable, and a proportion of curable lymphomas will be cured even in stage 4. So stage 4 has a different connotation and meaning in lymphoma than in other forms of cancer. And I think it's really important that people understand that, because it can be very frightening if they hear that they have stage 4, which in, for example, colon cancer would be a much less favorable circumstance. One thing that I would say immediately is that in any person's treatment, and this is specifically in the context of Hodgkin lymphoma, we want to use all possible treatments in the best possible way to maximize the chances of cure, but also minimize the risk of toxicity, both in the short and longer term. And so we know that chemotherapy, radiotherapy, and other treatments all have early and late toxicities. And the role of the MDT meeting, the multidisciplinary team meeting, is to assess the what is the most appropriate treatment for a given circumstance, and whether that should be chemotherapy alone, chemotherapy in combination with radiation treatment, or in some cases radiation treatment alone. This is typically in circumstances where cure is not likely and we're trying to palliate a certain condition. But so I would say that there is a role for radiotherapy in all types of lymphoma. The question is when and to what amount of radiotherapy, and how it should be combined with other treatments. And that, of course, is the role of the MDT, as mentioned, and the expertise of radiation oncologists, medical oncologists, and others in coming up with the best recommendation we can. So we want to make use of every therapy in the best possible way, and recognizing that all have a role to play in certain circumstances, but also having a view of the longer term and making sure that we minimize the risks to that individual in those future years. So an interesting question about follow-up. So this is really the time, once treatment is finished and the clinical team is happy with the outcome of that treatment, hopefully the individual is in remission, and we want to see how they go in the future times, and to continue to provide advice and to identify relapse and be able to recommend appropriate treatment. So that's the follow-up process. And typically what has happened in the past is that patients are seen usually 3 monthly in year 1, 4 monthly in year 2, 6 monthly in year 3, and then annually. And in the past, people were followed up indefinitely. But now patients are being, in some cases, discharged, or in others, recruited onto follow-up programs that allow them to make contact if there are problems and provide them and their GPs with relevant information. And that's something that we've done in Manchester with the so-called ADAPT program. So at the 5-year point, people who are likely cured of lymphoma, so these are people with Hodgkin lymphoma or diffuse large B-cell lymphoma in the main, we discuss with them the fact that if nothing has happened in the previous 5 years, the risk of relapse is now very small, but they need to be informed about the potential risks of the treatment they've received and how to reduce the risk of that. And so we provide them with bespoke information relevant to the treatment they've received. And we say, we don't need to see you again on a regular basis, but here's the information for you and your GP. And you can get in touch with us at any time if you want to, if you've got a concern or something you want to talk about. And this is the so-called ADAPT program. And this seems, we've now got nearly 900 patients recruited. It seems to be working very well. GP and patient feedback has been excellent. We're developing a patient-facing website and app, and we're also linking that with various messaging facilities so that we can prompt people to have the relevant test if they need a certain blood test at a certain time or a certain scan at a certain time, and so on. So that's, as it were, for the future. So in general terms, follow-up is an important period for patients. I think they find it very reassuring. I think there's a sense that we detect relapse best in the clinic visit. That we know is not the case, and what is much more important is that patients report new symptoms without delay so that those can be investigated appropriately. And beyond 5 years, I think that attending the hospital, certainly in our experiences, are necessary, but people do need relevant information, and I think they need the facility to be able to get in touch with us without delay if there's an issue. One of the main feedback points that we receive from patients is that they don't want to have to go through the difficulties of being referred into the hospital, which often was, or in some cases certainly was, delayed, and being able to access a clinical nurse specialist without delay is something that people seem extremely keen on having, and so that's built into our ADAPT program. So somebody's raised the interesting point about clinical trials, and I think this is a really important area. The only way in which we're going to make progress is by accumulating evidence, and we do that in clinical trials, and this can take many different forms. So there can be clinical trials that are observing what happens when we use certain new drugs in patients with disease that has come back after conventional therapy. So these are typically so-called phase 1, phase 2 clinical trials in relatively small numbers of patients, and they allow us to see whether drugs work, whether they're producing any side effects that are of concern, and how those are dealt with, and how patients feel about receiving those drugs. In phase 3 clinical trials, we're comparing a potential new therapy which is already being investigated at a phase 1 and phase 2 level. We're comparing that with an existing standard treatment to see if the new treatment is better than the existing therapy, or is it the same but has less side effects, or potentially is it worse, in which case it should be abandoned. So that's the view, or that's the role of the clinical trial, and it's such an important part of what we do. And I would certainly encourage everyone to ask about clinical trials in the hospital where they're being seen, to see if there's any access to a clinical trial, and to consider going to a centre where clinical trials are available if the current centre is unable to help. And the reason that that's important is that by getting access to a clinical trial, that is the way in which new therapies can be, that people can gain access to new therapies. And of course, a clinical trial is not compulsory. Patients can make a decision, having heard about them and read about them in the information sheets. They can decide whether or not they want to take part. And crucially, even if they decide to take part and consent, they can remove that consent at any time without having to give a reason and without upsetting the clinical team. So in other words, patients are in complete control, and they can press the bell on the bus at any time and get off that bus if they so decide. So clinical trials, in my view, are absolutely crucial to us making progress. Patients, I think, need to be offered clinical trials whenever possible, and they should seek out clinical trials if they're interested in doing so. And I'd just like to thank everybody who has taken part in so many clinical trials over the years in the UK and worldwide. The progress that we've made is absolutely down to that involvement. And increasingly, and quite appropriately, patients are being asked to guide the professionals in terms of what are the really important questions they want addressing, and what are the important factors that they want to be measured in any evaluation of a new approach or a new treatment. So clinical trials, I think, are really important, and I'd encourage you to get involved or to ask further questions. And Lymphoma Action, of course, can provide a lot of support in this area.